Hi, my name is Sydney Hudson,
Hi, I'm Shayaan.
I am Hriday Parekh.
And I'm Mr. Satiar.
and today we're going to be presenting a review on the efficacy of two B-cell targeting biologics in treating systemic lupus erythematosus. We've affectionately titled our presentation to B-cell or not to B-cell. But what are B-cells? And more importantly, what is lupus? Well, in a healthy person, B-cells, a type of white blood cell in the immune system, represented here by the blue circle, produce antibodies which bind to antigens as part of a normal immune response, as you can see in this figure. However, for people with the autoimmune disease known as systemic lupus erythematosus, otherwise called SLE, antibodies are overactive and targeted unnecessarily against healthy tissues, as can be seen on the right, ultimately leading to effects such as inflammation throughout various organs and body parts. The cause of SLE is not entirely known, but it is often thought to be due to a conjunction of genetic predisposition and other factors, such as having an infection, being exposed to certain environmental factors, or taking certain medications. SLE is characterized by several variable genotypic and phenotypic etiologies, making it particularly difficult to diagnose and treat. Non-medical treatments such as wearing sun protection, maintaining a normal healthy diet and exercise routine, and refraining from smoking are sometimes helpful for managing SLE symptoms, especially moderate ones. However, organ-specific treatments are also commonly used in increasingly severe cases of SLE. The most frequently used of these treatments are immunosuppressant drugs, anti-malarial drugs, corticosteroids, and biologic agents. Our review focuses on biologics, which typically work by downregulating B cells through different pathologies. As of now, the only Food and Drug Administration, otherwise known as FDA, approved biologic drug for SLE treatment is belimumab, commonly shortened to BEL. But another one, known as rituximab, or RTX, functions similarly and has been shown to be effective under certain circumstances. How do these drugs work? Well, in general, B-cell lymphocyte stimulators, shown here in green, are needed for the activation and survival of B cells, allowing for inflammation and other side effects in SLE patients. Belimumab, shown here in orange, works by binding to these B-cell lymphocyte stimulators, as you can see, in turn preventing them from binding to the B cells and ultimately inhibiting their survival and prohibiting them from attacking healthy tissues. Rituximab, on the other hand, shown here in red, works by binding to and depleting the B cells themselves, thus, in a similar way, preventing the survival of B cells and barring them from attacking healthy tissues in SLE patients. When belimumab is taken alone, which is often the case since it is the only FDA-approved biologic to treat SLE, the incidence of symptom flares is observed quite frequently after the end of the treatment period. Recent studies have demonstrated that when belimumab is taken at the conclusion of rituximab treatment, these flares are decreased dramatically. Now we're going to be looking at what methods we can use to compare the efficacy of these two biologics.
The most used global index of activity is SLEDAI, which stands for SLE Disease Activity Index. It weighs various symptoms or illnesses that can develop from having SLE. So here are the actual items that the SLEDAI scale considers, and each one holds a different weight, such as how the lupus headache, which is a persistent migrainous headache that doesn't respond to narcotics, weighs 4 points, whereas a fever just weighs 1. It then sums them all to produce a score, which is meant to be indicative of the severity of lupus that a patient has. So the biggest advantage of SLEDAI is that it's very simple to score. So it's the most commonly used index in clinical practice. But the negative of it is that only the presence or absence of each item is considered, not the extent or severity of it. But because it's so easy to use, research has been conducted evaluating both belimumab and rituximab individually, as well as together using the SLEDAI scale. So in terms of rituximab research, a study conducted in France randomly assigned patients with SLE to either take rituximab or a placebo. And after monitoring the groups for 6 months, they found a decrease in SLEDAI score in the rituximab group from 10.8 to 3.4, which is a mean delta of 7.4 points. However, they did notice a large standard deviation, and so they decided to further divide the groups into rituximab patients who were taking the drug along with immunosuppressive agents and those who were not. Immunosuppressive agents is noted as IS in this slide. The rituximab group had an average of 2.1 SLEDAI score, and the group taking IS agents in conjunction found a score of 4.6. Since the lower score indicates less lupus activity, they concluded that the rituximab monotherapy group was the most effective. For belimumab, in another study, SLE patients were randomly assigned to 3 doses of belimumab treatment, either 1, 5, or 10 milligrams, or were assigned to a placebo group. After they monitored the groups for 52 weeks, they didn't find a significant difference between the experimental and placebo groups, and decided to focus specifically on serologically active SLE patients, which is lupus activity affecting blood serum. Belimumab treatment resulted in significantly better responses than placebo for SLEDAI score, with an average of 28.8% SLEDAI score decrease versus 14.2% for placebo. This corresponded to a p-value of 0.0435, which is considered statistically significant. These results were reproduced when the same study was conducted for 76 weeks, and the same reduction was found, which showed that belimumab was effective as treatment in serologically active SLE. In the case of both, case studies were done on 2 patients who specifically had lupus nephritis, which is the most common type of SLE that targets the kidneys. The first case, a 32-year-old female, had a flare and was given rituximab. After 18 months, they paused rituximab treatment and monitored B-cell counts. And before repopulation could occur, belimumab was administered as a follow-up. Her SLEDAI score decreased from 22 to 6 over the course of 18 months. The second patient, a 42-year-old male, was given rituximab after he had a relapse. And 20 months after the initial dose, he was started on belimumab. His SLEDAI score decreased from 10 to 4. Both studies concluded that administering belimumab before B-cell repopulation by rituximab was highly effective, and the overall consensus in terms of SLEDAI scoring was that combined belimumab-rituximab treatment had the highest average decrease in score.
Another method of evaluation of SLE is the British Isles Lupus Assessment Group Index, aka BILAG. The resulting BILAG index, after modifications made for accuracy, measures disease activity of SLE by the assessment of 8 organ-based systems using various symptoms and lab variables. Each system is given an alphabetical score denoting its severity of SLE. For reference, a BILAG A score is the most severe score, while a BILAG E score corresponds to no SLE activity being present in the system. Due to its structure, an advantage of BILAG is that it can be used to determine the potential treatment of a patient with SLE. On top of this, disease progression, such as improvements or relapses, can be determined for individual organ systems, allowing for the identification of a treatment's successes and failures. However, due to the complexity of BILAG as a system of measurement, a disadvantage is that an algorithm must be used. This becomes an issue in studies because a clinician has to learn how to use the programming prior to beginning a study. The following studies of different treatments utilized BILAG as its measures of efficacy. The rituximab study performed by Merrill et al. Considered clinical response as improvement characterized by achieving BILAG C scores or better in all organs without experiencing a severe flare, which was defined as 1 new organ system receiving a BILAG A or 2 new BILAG B scores. 70.4% of those receiving treatment experienced no clinical response, meaning no worsening, while 71.6% receiving placebo experienced the same. In a study published in HHS author manuscripts by Fury et al., assessing the efficacy of belimumab on SLE, no worsening was defined as no new BILAG A organ domain score and no more than 2 new BILAG B scores. After 52 weeks, the BILAG index indicated no worsening for a greater percentage of patients receiving treatment, 74.9%, versus placebo, 65.5%. The treatment protocol of belimumab after rituximab showed promising results. The proportion of participants with a moderate or severe disease flare, defined as a new BILAG A or 2 BILAG B scores, was measured as the primary endpoint. Thus, patients not experiencing a flare was considered no worsening. In the study by Shippa et al., findings revealed that belimumab decreased the risk of a severe flare, with 89.3% receiving treatment not worsening, compared to 64.2% with placebo. In addition, this protocol showed no adverse effects on any patients. By comparing the results of each of the 3 trials with the BILAG index, the treatment of belimumab after rituximab has a greater efficacy on SLE than either treatment individually.
Another test besides the BILAG is the anti-dsDNA test, which is a tool used for measuring the levels of anti-dsDNA antibodies in your blood, such as those seen in this picture here. High levels of these antibodies are indicative of SLE. One major benefit of this test is its accuracy, as it requires a blood sample to be drawn in order for anti-dsDNA levels to be measured. However, because of this, one major drawback of this test is its accessibility, as it requires specialized equipment by professionals in order for it to be conducted. So it may be harder for someone to have the test done if they can't afford seeing these professionals. Now, what exactly does this test have to say about current SLE biologics? Well, according to a 2012 study by Rovin et al. On the efficacy of rituximab, they found that the median percent change from baseline anti-dsDNA levels was about 70% for the rituximab group and 40% for the placebo group by the end of the study. In another 2012 study by Stoll et al. On the efficacy of belimumab alone, researchers found that anti-dsDNA levels also decreased from the baseline at the start of the study, with a median percent change of about 40% by the end of the study at week 52, compared to the placebo group's median percent change of only around 10%. Just like rituximab, here too, belimumab performed better than the placebo group. So while both rituximab and belimumab appear to decrease anti-dsDNA levels, which is generally indicative of an effective SLE biologic treatment, what would happen when you combine the two? Well, in one major 2021 study by Shipa et al., researchers found that when compared against a placebo, the addition of belimumab to previous rituximab treatment resulted in a decrease in anti-dsDNA levels, with a 70% decrease in the treatment group and a 15% decrease in the placebo group. So based on the anti-dsDNA test alone, we can assume that both rituximab and belimumab alone do result in a decrease in anti-dsDNA levels. However, they are most effective when combined together. Now, after looking at all three scales of SLE, what about the drawbacks to the treatment? How many side effects do these drugs cause? Well, for rituximab, belimumab, and both of them combined, the adverse effects vary. For example, in one 2010 study by Merrill et al. About the efficacy of rituximab alone, they found that while 37.9% of patients experienced some kind of significant adverse event, a near identical amount of the placebo group also experienced some kind of adverse event at about 36.4% of patients. The similar percentage between the rituximab and placebo groups indicates that rituximab probably doesn't cause significant adverse events, at least on its own. Overall, though, rituximab did cause about 1 to 2% more adverse events in this study than the placebo group. In another 2009 study by Wallace et al. About the efficacy of belimumab alone, it was found that for patients that have experienced at least one significant adverse event, the belimumab group experienced a lower rate of adverse events at about 16.2% compared to the placebo group's 19.5%. However, overall, in contrast to rituximab alone, belimumab did result in less adverse events than the placebo group. Lastly, in one combined study, researchers discovered that when belimumab was taken after rituximab, the rate of significant adverse events was 23% for both the biologic and placebo groups. So, at least based on these studies, rituximab, belimumab, and both of them combined tend to not have a significant impact on adverse events. However, belimumab was shown to have a lower rate of adverse events compared to rituximab alone, and when both of them are combined, the rate of adverse events was still lower than rituximab on its own. Generally, though, the adverse effects are limited more so in a combined regimen of both rituximab and belimumab than if they were to be taken separately.
Overall, we saw a common theme among all the methods of evaluation. To recap, for Hriday, we saw that as opposed to individual belimumab and rituximab treatment, belimumab administered specifically after B-cell repopulation by rituximab decreased the overall score most. Using the BILAG scale, we similarly noticed that belimumab after rituximab B-cell depletion was the most effective at reducing that category of SLE organ activity. For anti-dsDNA, we saw that belimumab was the most effective when given 4 to 8 weeks after rituximab. However, we did notice that in terms of adverse events and symptoms that could lead to flares, belimumab was the least detrimental, followed by combined belimumab and rituximab treatment, and finally rituximab monotherapy having the most adverse effects. So, in general, it can be said that belimumab given after rituximab treatment may be the most effective biologic in treating lupus. However, in specific cases where adverse effects might have a detrimental impact on a patient's life, it may be more important to prioritize preventing flares by giving belimumab monotherapy instead of a combined treatment.
In addition to this data, there are other factors that need to be considered in the evaluation of belimumab and rituximab, and hopefully can be touched upon by future research. First of all, during our literature review, we noticed statistically significant variability when focusing on subtypes of SLE. such as lupus nephritis and serologically active lupus, as mentioned in the SLR scale studies. Future research should explore how these subsets of illness react differently than SLE, and which biologic may be best when a patient has a more localized lupus experience. Also, in some case studies, there were specific symptoms that either arose from the biologic treatment or worsened after the first infusion. For example, the prescription of belimumab and rituximab together often affects the skin with scabies-like rashes and ulcers. A more patient-specific approach to care would help to address some of these risks, since the heterogeneous nature of lupus activity makes it less generalizable for treatment. It is also important to consider the limitations of the current disease activity indexes we have, as mentioned before. So it's important to realize that even with statistically significant differences as found, the core of the research, which is the scores and measures from the scales themselves, may not be the most representative of the true disease activity. In the future, a scale that addresses the limitations of both SLDI and BILAG, simplicity without compromising quality, could build the future for a much more quality lupus research. So with that, we hope you enjoyed our presentation, and thank you so much for your attention.